I can also thank the organizing team for this opportunity. And I hope you had an excellent session yesterday as well. So the session is mainly on acute abdomen, so nothing new, and almost every one of you actually dealing in day in and day out practice. So a bit of abdominal compartment syndrome, even though actually it's more debated, so actually it's not too frequently seen, but in comparison to the acute abdomen. So I'll take you through a little quick brief overview of approach to a patient with acute abdomen and how will you approach a patient actually who is having a high intra-abdominal pressure. So acute abdomen, if you see, it's nothing but any condition that is very acute, that means sudden onset, that actually requires a faster intervention. That is a very simple way of telling any acute abdomen. So it is very common in ICU, and it's not in ICU, maybe a non-critically ill patient acute abdomen is seen. So especially patient is very sick, they land up in ICU, or else they'll be land up in OT or maybe in a high dependency unit. So if you see the causes, you can group it into either is related to hollow viscous or maybe solid organ that is in the abdomen. So predominantly it is more of infectious etiology. Like it can be perforation, or it can be intestinal obstruction, volvulus, or inflammation. To give example, it could be pancreatitis, or can be vascular cause. So like abdominal aortic aneurysm rupture, maybe dissection, etc., and mesenteric ischemias. And these are the common groups we commonly see in intensive care unit. If this is a very old study, and if you see the epidemiology or what are the common causes, what they have found, still the bowel ischemia, intestinal obstruction, infectious cause actually is quite high. And this is one study done recently from CMC Bellu. It's from emergency department, where patients who come with abdominal pain. What are the common causes? If you see here, actually it's a ureteric colic. That is the most common cause. That is they found in their cohort. And apart from that, actually the common thing is appendicitis and pancreatitis. That is commonest cause for abdominal pain. So why it is more important is, if you know the common cause and local epidemiology, it will guide you in a way that how to investigate and how to think in a better way. Because ICU patients, sometimes they may get intubated and they will land up in with you. They will not have all hard signs of clinical examination. You have to more rely on history, that's most. And second thing is on investigations. So by knowing this epidemiological data, it will be actually helping you to think differently. And if it is a Brazil or Western world, and you may get more of ischemia, like Westerners, they have more like ruptured abdominal aortic aneurysm as well as dissection as one of the important cause for their acute abdomen. But developing countries is still more infection, intestinal obstructions, peritonitis, and these are the common causes. If you just rule out the surgical causes, medical causes actually quite less common in terms of acute abdomen, and it may not be very sick enough to land up in an intensive care unit. So what are the common challenges we face? One is identification of acute abdomen in ICU, especially in a patient who is mechanically ventilated on sedation or analgesia, and to localize it, because the patient is the best person to actually indicate where exactly. And the history given by relatives may not be actually very apt. They always will tell patient was rolling around, patient having abdominal pain here and there. It's very, very difficult. And how to evaluate, is there any common approach, and how to manage. So if you see here, the commonest, still more important symptom for any acute abdomen is abdominal pain. Still it's most common. Either it's a critically ill or non-ill patients, abdominal pain, along with other GI symptoms like nausea, vomiting. And quite common we see patient who comes with abdominal discomfort or distension, and altered bowel habit is of the most important history you should ask. Patient is constipated for 4 days, 5 days, obstipation, and the patient may have a continuous loose motions coming with ileus. This is one of the commonest history you should ask. And especially to concentrate on ICU patients, one of the commonest trigger factor to evaluate is the high RT aspirate. If it is consistently high, it's one of the trigger, but it may not always tell there is a severe pathology going on. It could be even simple pathology, but it acts as a trigger to evaluate further. And bleeding PR, and because actually many times intestinal ischemia, they may suddenly present with the bleeding PR. You may do a CT scan and find that there is intestinal gangrene. And other more important things is unexplained high lactate. Commonly we see if lactate is quite high, it puts our concentration to look at abdomen, what's happening in abdomen. Either it's a liver or maybe it's intestine that is actually at harm. Unexplained sepsis, you just search everywhere. Even olden days teaching, if you see, if you couldn't find the cause of fever, look at the diaphragm. It's one of the old teaching. So that way, ICU patient is the most important things. When you're actually clueless, where you're actually dealing with, abdomen could be the source. And if you're having high lactate, persistently high, unable to explain by other common means that is in ICU, still look at the abdomen. And high RT aspirate is an important trigger. But quite often, we see patients who have a completely silent abdomen, nothing. You take a mild discomfort. If you see CT scan, they may show intestinal ischemia, and many times surgeons have surprised opening abdomen, bowel is gangrene. So many times we have come across these situations. There's a problem in ICU because many times the features are completely confounded, especially uncontrolled diabetic who have a neuropathy and who have a gastroparesis, and a patient who have been heavily sedated and on analgesia, and patient on palliative care on morphine tablets. So many confounding factors will be there. You may not get all hard signs. So these are the common the causes what I have, because at least 30 to 40 causes are, if you keep filling each boxes, it will be very difficult. But common causes what we see in ICU, one is either calculus or acalculous cholecystitis. Appendicitis is not too drastically critical to come to ICU, but still one of the common cause for acute abdomen. And many times we see patients with renal colic, with pyelonephritis in ICU, colitis and diverticulitis. And especially in immunocompromised patients, enterocolitis is one of the things that we should not never miss. And diverticulitis is also one of the important cause. And many times we land up in a patient having a CME colitis. These are the common things we should keep in mind, and that triggers the evaluation. Here, more or less clinical, and because of the availability of ultrasound, it becomes still more easier for us to and extend our clinical examination by putting a probe in the abdomen to find out the important causes. That's more important. So it's always clinical, never miss it, especially the history part and a quick physical examination. Definitely in ICU, we are going to rely more on little bit of more investigations when actually we are more clueless and your clinical examination is either equivocal or it didn't give you much data. So in that situation, ultrasound, if it is useful, that is first modality of screening. And many times we'll end up in a CT scan to expand our investigations. So especially in patients who are mechanic ventilated, who is too sick, where time is extremely important, because we should go for an early intervention. That means actually imaging should be add on along with your clinical examination. So this one study, it's not a meta-analysis, it's like a literature search. They try to find out all cases of acute abdomen came to hospital less than 5 days of history, and try to make some kind of recommendations. What I found is the clinical assessment is insufficient, but only it could differentiate between urgent and non-urgent causes. That means it cannot tell you what exactly the cause, but it can grossly give you an idea. And a patient is having a severe guarding rigidity, it tells you something really sick. Peritonitis could be a possibility. And CT scan is one of the most important investigation, the choice in critically ill patients. But definitely ultrasound to be start with the screening because it's available at the bedside. So if you see this recommendation with the radiology, CT scan is top on the list. There is no debate on it. So it is one of the most useful and most appropriate investigation, either in a medically ill or maybe operative patients. And second most useful test is bedside ultrasound. So many investigations are listed out, and that may not be actually always useful. If you do the CT scan, especially contrast enhanced, when you actually don't have a clinical source, and that should be the first and stop when patient is too sick. So this is one of the important case series I came through. I searching for this acute abdomen. It is a mnemonic where A for looking for aneurysm of aorta, C for collapsed IVC. I am not sure why this C is actually collapsed IVC, maybe a hemorrhage or something related to that. Ulcer and D ulcer and trauma related and ectopic. Ectopic is one of the important things actually we miss. So that's one of the important history we should always ask. In abdomen, appendicitis, biliary tract, descended bowel loop, and obstructive uropathy. And Men is for testicular, and woman you should just look for ovarian tarsal. So maybe you can just go through one by one and keep assessing the patient by ultrasound. If you want to just use only ultrasound, maybe this is the way. look for the aortic flow first, and look for the fast scan for trauma, then look for gallbladder and liver status, and look for other 4 pockets of abdomen. That gives you a clue. So this is a brief overview of acute abdomen. I just quickly go through the next important topic of intra-abdominal hypertension and abdominal compartment syndrome. So intra-abdominal hypertension, it is most important catchword is sustained. Sustained elevation of pressure. It's not only one time. If you measure pressure in a patient randomly, the pressure will be always arbitrarily high and low. It can even reach 20, come to 10, 5, 4, so many numbers. But if consistent, persistently high, more than 12, that is one of the important alarming signs that patient is having a high abdominal pressure. Or if you are getting the same value repeatedly, and 12 then becomes 10, again 14, again becomes 10. Keep on getting one abdominal value when you are frequently monitoring patient. That also is important trigger for further evaluation. So this abdominal pressure actually been graded to give us still more appropriate idea, so that we monitor frequently and we may escalate our actually the investigation as well as care. If you see the numbers, and 12 to 15 is grade 1, and grade 2, grade 3, grade 4 actually sequentially goes. So whenever if you want to define a abdominal compartment syndrome, it is any sustained high pressure that is more than 20. That is number 1. Second important thing is development of new organ failure. It is not existing organ failure. It should be a new organ failure that should be explained by your abdominal pressures. It is not something organ that is failing, and that is not because of abdominal pressure. There should be rationally correlation between both. And initial days before this definition was actually fixed, when the World Society of Abdominal Compartment Syndrome was formed, before that so many definitions were there. Before that they used to use a term called abdominal perfusion pressure. So if you have to have a compartment syndrome, they used to tell your perfusion pressure should be less. But when they recoined, they told that despite low pressure, if you meet this criteria, then you should take as a abdominal compartment syndrome. Even though this definition is still holding good for nowadays practice also. If you see the techniques, and at least 10 or 12 techniques are all are debatable techniques. So finally the experts with the different studies background, they fixed one important technique, that is transvesical. Before that transrectal was there, and directly measuring gastric was there. So many techniques were tested. But the bladder technique was, one is easy and it is feasible, it is repeatable, and the variation was much lesser. So putting together so many factors, and they have chosen this technique to be widely adopted to every patient, unless otherwise it's actually required. For example, patient has undergone a bladder surgery, patient is having ileal conduit, so many things will be there where you go to a next reliable technique. Or else you go for first important techniques, transvesical technique. The most important thing is patient position. Just a slight elevation of bed is going to increase your abdominal pressure. That's why the supine position is most important. And the studies that is done in a spontaneous breathing patients, just because your diaphragm contracts during inspiration, your pressure increases. That's why it is measured in expiration and at the level of iliac crest, mid axillary line, and how much volume you are going to put. Drain the bladder completely first. The bladder is empty now. You put a saline 20 to 20 cc because you need a continuous column of some water to measure the pressure. So you should not put more, and you measure the pressure and just wait for some time, so that pressure actually giving a constant value. So these are the delicate steps you should follow. If you miss one step, the next reading you can't compare. That is the only important thing. If you are actually unable to give a supine position because of any reason, you come to near supine position, and every time you keep doing the same position and same way of measurement. That is the most important, because here sustained high pressure is more important. That means you have to keep repeating the values. So that's why it is most important. So causes, lot of causes, intraluminal, extraluminal, and if you want to divide into two important things, so one is increased abdominal contents, other is compliance, either is abdominal wall or maybe from a thorax. So it's a tight binders or extras, severe burns, dressings is there, and tension sutures sometimes they are put. So all these are common causes for reduced abdominal wall compliance. So these are the risk factors. That means the patient having an intestinal obstruction, so this patient has high risk of getting maybe high pressure. He may not be having today, but he is at high risk. Patient having acute necrotic pancreatitis, high risk of getting a intra-abdominal hypertension. Patient is having a severe intra-abdominal abscess, high risk of getting a intra-abdominal hypertension. So these are the high risk factors. If you see how actually the effects, one thing is pressure is high in abdomen, and always there will be a reflected high pressure in thorax. It's never a single compartment, even if it's a misnomer, always it is a thoraco-abdominal, because always diaphragm actually springs the thorax every time. So here the most important thing is there is high pressure in the abdomen, so your abdominal distension will be there, and there will be actually compression of inferior vena cava. So that will cause actually a decreased venous return because of elevated pressures. And what will happen? Your actually thoracic pressure will increase. So intrathoracic pressure will cause increased cardiac pressures, and there will be a associated sympathetic activity that will cause a vasoconstriction. So venous return is less, vasoconstriction is happening, and there is a pressure outside abdomen aorta which is quite high. That leads to a reduced cardiac output. There will be a increased pulmonary vascular resistance and systemic vascular resistance, and total lung capacity will be less, FRC will be reduced, gut severely hyperperfused. So these are the actually sequelae of your intra-abdominal hypertension when it is more severe. So obviously you will be getting these kind of signs, symptoms when you evaluate the patients. So similarly, the term called polycompartment syndrome has been defined, and because it's never a single compartment, I told it's a more of a thoraco-abdominal syndrome. So when it actually affects your intracranial pressures, like in terms of altered sensorium by increasing your venous pressures, draining your brain, so high ICP, it becomes a third compartment. So any compartment, that means two or more anatomical compartment has elevated pressures. That means in the compartment pressure usually we measure in terms of venous pressures. If it is high, then we call it as a polycompartment. But whatever the pathophysiology, whatever discussed in last slides, almost holds good. This is one of the summary slides. So the mechanism was already I put, it's already 16 minutes only here. So what are the mechanism I have put here? So hypoperfusion, these are the mechanisms. But how patient presents is exactly by oliguria, high intrathoracic pressures, and high refractory metabolic acidosis. The way patient presents is like this, and how the mechanism happens is because of this that is shown in the left side. These are three common types. Primary, that means pathology is in the abdomen. Secondary is extra abdomen. Tertiary is repeatedly increasing abdominal pressures. So most important slide is this slide. So management is a conceptual model. If you want to have a high pressure abdominal compartment, three important things: pressure dynamics. What is the pressure? It is extremely high and is persistently high. One most important information. Second, what kind of a cause? If it is surgical cause, second most important information. And what is the rapidity of worsening? That is the important cause. If your pressure is extremely high, rapidly worsening organ function, that can be explained by your high pressures. That is the most important thing. So you should just always take. And to split this into a small thing, how to manage, these are the medical measures, where actually I put it sequentially, and this is through the guidelines from World Society of Abdominal Compartment Syndrome. Whatever I put in green is the last intervention you do in that compartment. So you decompress the system, and you stop enteral nutrition temporarily, and abdominal wall complex you release whatever the pressures and neuromuscular blockades. And if you're having a high volume overload, you dilute the patient, and extraluminal contents you just keep a watch, and keep a watch on your perfusion. What is the last modality? The most important modality that will be useful in an ICU patient is to open the abdomen, push the patient to the OT. And more sophisticated centers, they open the abdomen at the bedside itself. But still, our ICU, many places, it's not very comfortable to open the abdomen. They push the patient to OT. So snapshot, patient having high pressures, they cause tissue perfusion. How? Because of a high CVP or high intra-abdominal pressure, your perfusion reduces. We have to reverse back from this situation to this situation. Better to avoid going to this situation. So when to intervene and how to intervene? So that's no doubt. The timing of intervention, when the pressure is very high, the rate of increase is very high, 20, 25, 30, it's drastically increasing high, and it's a surgical cause for abdominal compartment syndrome. Difficult to maintain your hemodynamics or maybe ventilation, oxygenation. If any of the things yes, more yes to these questions, then that is the time actually you should start intervening these patients. How to intervene? Medical or surgical measures. Again, if any of things is yes, very high pressures, or if pressure is very high, you have to bring it back to normal. That means the drastic reduction cannot happen with medical measures. You have to open the abdomen. So this is a situation you will think of when to choose which modality of treatment. Finally, touch up on open abdomen, because once the patient goes to OD, you will come with open abdomen. So the most important thing is hypothermia. It's very difficult to manage with because we cannot put a blanket over abdomen. We don't have other measures. It's very tough to manage. One of the important things. Many of these patients have bleeding diastasis. So with hypothermia, it becomes a more deadly combination. So nutrition, they are very high demanding, highly catabolic, open abdomen. So preferably enter nutrition if they are tolerating well, or else we should think of a TPN for a short period of time. So negative pressure wound management is the best, but many times we end up in using Bagota bags, that is a resourceful medicine techniques. If the patient requires a damage control surgery that requires a re-exploration, then maybe done within few minutes, 1 or 2 days. So this is a classification. It has been open abdomen with a bowel stick or intracranial fistula is formed or not. Based on you have a classification, and more the severity, more is the problem, and difficult the patient, and patient will take a long time to recover back. These are the few key papers, apart from 2 excellent papers that I shared with you as a reading material. These are the few important papers I just put it here. And to summarize, acute abdomen is quite common. Identify the risk factors. If you have a risk factors, and start measuring your intra-abdominal pressures. Always keep in mind the position of the patient, IAP values, and how much it is most important. Cost for the intra-abdominal hypertension, surgical cost, and organ failures. So thank you very much.